Hello, and welcome to today's session on ear emergencies, which is part of the Introduction to ENT course to get you ready for rotations in ENT. My name's Ben Talks, and I'm an ENT Research Fellow in Newcastle upon Tyne. This is just a quick disclaimer to say this course isn't a substitute for formal medical training, and this is the first of a 4-part series. We're actually re-recording it today because we forgot to record the original session. So just an overview of what we're going to go through. We'll go through otitis externa, Pinna cellulitis, otitis media, facial palsy, sudden sensorineural hearing loss, general triage of the discharging ear, and then go through some interactive cases to kind of consolidate on this. So starting with otitis externa, it is very common infection of the external ear canal, makes up 1 in 6 new patient referrals to outpatient ENT, although the vast majority of it, 90%, is managed in primary care. Common risk factors to be aware of are cotton bud use, which is a big one. Always remind patients not to do this. Swimming, particularly in open water, as well as hearing aid use, earphones, anything which involves stuff going into the external ear canal. And then the common organisms are Pseudomonas, Staph aureus, Staph epidermis, and Candida. So on examination, you tend to see something a bit like this. It'll be painful, particularly when you insert the speculum. Although some patients describe as itchy, you'll typically have a discharge, which can be described as custard-like. And it'll all look red and tender. Erythematous like this may well be narrowed in severe cases. It can get the canal can become very narrowed, and there may or may not be some extension onto the face in terms of cellulitis involvement of the pinna in more severe infections. So the mainstay of management is topical antibiotics, kind of that underlying topical, not oral, and microsuction. So it's reasonable, just because of the volume of cases, it's reasonable to ensure that patients have been treated with 7 days of topical antibiotics before being seen in clinic, as this does resolve most individuals' problem. However, if patients have not improved after 7 days of treatment, then they should be seen by ENT in clinics for microsuction to help clear out the debris, because that's often the problems, that the topical antibiotic steroid drops aren't getting into where they need to. However, you do also need to be aware of some red flags, which we will go through as well, which you might have to see them a bit earlier. So, as I say, if the first-line treatment's failed, then we should make sure you've got a swab to look for microbiology and so culture and sensitivities. Another possibility, if the canal has become severely stenosed so that you can't actually see the tympanic membrane, the drops aren't going to be getting in, so you might need to insert a pope work. So this is kind of a little bit of sponge that sort of gets inserted into the ear, and it just helps conduct the antibiotic steroid drops into where they need to go. However, if you have put one of these in, you then need to see the patient back in kind of up to not later really than 72 hours, because obviously you have inserted a foreign body into the ear, so you don't want to leave it there for too long. If patients have got fungal infection, which typically follows multiple antibiotic courses, then they need prolonged treatment. So this is about 4 weeks, and you need to treat them for 2 weeks after the symptoms have resolved. And the other big thing to say is patients should keep their ear dry whilst they've got an active infection. So this involves kind of not going swimming. If they're in the shower, they can make a little plug, so you can get cotton wool, dip in some Vaseline, and form a little plug to keep the ear dry. But yeah, so risk factors, as we've kind of mentioned, there are some severe complications of otitis externa, which we're going to go into. The main one being necrotizing otitis externa that we worry about the most. So risk factors include having comorbidities like diabetes, increasing age, so particularly over 65 years of old, having had recurrent acute otitis externa, or any form of immunosuppression, whether that be patients on chemotherapy or taking medications for autoimmune conditions. If you are someone who likes to use scores, then the ear score has been developed, and it's just a way of kind of profiling patients' risk of complications based on these sort of factors. So you can have a look at that. Red flags that you should sort of check with new referrals is how bad is the pain and is it interrupting them from their sleep, with that being kind of a worrying sign of something more severe like necrotizing otitis externa. Do they have complete stenosis of the ear canal? Because if they do, topical treatment's not going to work and they're going to need a wick to be inserted. Do they have any pinna or periauricular cellulitis? Again, this is a reason that patient will probably need oral or IV antibiotics and may need hospital admission. And do they have a cranial nerve palsy? Again, a big red flag for necrotizing otitis externa, which needs treatment of IV antibiotics. So as I've mentioned, this is kind of the worst case scenario that we're worrying about. And then we'll come on to that a bit more later in this talk. So now moving on to pinna cellulitis and perichondritis. So pinna cellulitis is infection of the skin of the ear. It can also be a complication of otitis externa or can follow insect bites, eczema. Psoriasis, having dry skin makes you more likely to get skin infections sort of everywhere, also on the ear. And it's typically from skin commensals, so something like Staph aureus. Whereas pinna perichondritis, on the other hand, is infection of the ear cartilage. And this typically involves some kind of penetrating trauma of the cartilage, such as an ear piercing. And the bug in question is normally Pseudomonas. Now, how do you tell them apart? The big thing is that pinna perichondritis is typically earlobe sparing. And the other thing is there an abscess or any kind of necrosis of the pinna you need to worry about, particularly if there's an abscess. This patient's kind of going to need urgent drainage of that. And then slightly more into the weird and wonderful, but does it affect both their ears and their nose? Is it kind of, would be unusual, obviously, for an infective condition. And if it does, then you should have in the back of your mind relapsing polychondritis, which is actually an autoimmune condition rather than an infective condition, which is sort of can sometimes be mistaken for pinna perichondritis. So how do we treat it? So this varies a bit depending which centre you work, so you should be aware of what your local protocol is. But generally speaking, as an inpatient or an outpatient, so depends if they've got an abscess, they're almost certainly going to be admitted, or if they're systemically unwell. And then, as I say, oral versus intravenous antibiotics, typically both pinna cellulitis and perichondritis would involve hospital admission for IV antibiotics. However, some centres are now moving to antibiotic treatment with things like oral ciprofloxacin, which has equivalent bioavailability between oral and IV routes. And in my centre, we tend to treat with oral flucloxacin and ciprofloxacin as an outpatient, as long as the patient's systemically well and doesn't have an abscess. But look at what your local practice is. Then moving on to otitis media. So this is a very common condition, typically of young children, so less than 7 years old, and the vast majority of cases are viral and self-limiting. In terms of bugs, you can get, it's typically kind of middle-ear organisms, so strep pneumonia, Haemophilus influenza, or influenza virus, and GPs probably see even more of this than we do in ENT. So presenting features, typically severe otalgia, which gets gradually worse until there's some discharge and the pain eases off a lot, often associated with fever. On otoscopic examinations, tympanic membrane will be red and bulging. And because of all this fluid in the middle ear, you typically get some hearing loss and maybe tinnitus associated with it. So this is sort of an area for antibiotic guardianship that's kind of being promoted, is that most cases will resolve themselves, typically within 3 to 7 days, whether you give them antibiotics or not. So there's no difference in terms of immediate or delayed antibiotic prescribing in risk of perforation, hearing loss, or complications. However, there is a slight reduction in pain if you treat with antibiotics, although you do have to treat 20 patients to receive one benefit. whereas obviously there's the negatives of kind of GI upset and things from treating with antibiotics. So deferred antibiotic prescribing is certainly encouraged in children. However, obviously using your clinical judgment, so reasons to prescribe antibiotics immediately is the child sort of systemically unwell, have they got bilateral otitis media and they're under 2 years old, or is it sort of suppurative productive otitis media? If so, then antibiotics are very reasonable. Oral antibiotics, typically people prescribe short course of amoxicillin, 5 days. If you've got a suppurative ear, topical antibiotics are an alternative option, and for persistently discharging ears are often the way to go. So people worry about otitis media because it does have several nasty complications that you should be aware of. So red flags for these complications would be, is that the patient are they septic, so systemically unwell? Do they have any swelling, cranial nerve palsy, meningism, altered conscious associated with this ear infection? And what you're worrying is kind of going into mastoiditis and the intracranial complications. So intracranial complications being, we kind of alluded to, but meningitis, sigmoid sinus thrombosis, brain abscess, extracranial complications being facial nerve palsy, mastoiditis, petrositis. So being aware of this is important. Obviously, patients with these complications are going to need hospital admission for treatment. So mastoiditis is often worried about, so having an idea of what you would expect to find on examination is important. So for a child with mastoiditis, they will be systemically unwell, so often have high, present septic. On examination, they'll have a bulging red tympanic membrane, permanent discharge, and a good sort of examination feature to look for is loss of the postauricular sulcus. So they kind of have this bogginess behind the ear, so you lose that postauricular groove. Having good going boggy edema over the mastoid is really quite a late presentation, and as is sort of forward displacement of the pinna, because obviously to have either of those features, you have to have really quite significant swelling. Okay, so moving on to facial nerve palsy. So the first question is it an upper or a lower motor neuron problem? Because you obviously want to exclude a stroke, and if they've had a stroke, you don't want them to be referred to ENT outpatients. So upper motor neuron lesions are typically forehead sparing, whereas lower motor neurons conditions involve the forehead. And differential diagnosis, if you've got a lower motor neuron palsy, is Bell's palsy or idiopathic palsy. However, obviously to diagnose that, you have to have excluded other causes. Ramsay-Hunt syndrome, which is a viral mediated from herpes zoster virus reactivation. Ear infections, which, as we've kind of just talked about, if you've got severe ear infections, can cause facial nerve palsy, parotid masses, or obviously any trauma. And you can grade facial nerve palsy according to the House-Brackman scale. And the important tipping point is really this 3 to 4. So at stage 3, eye closure is intact, whereas from stage 4, you have eye closures compromised. And that's really important, because if eye closure is compromised, then good eye care is essential to ensure that patients don't develop corneal damage. So you need to be prescribing lubricants and taping their eyes closed at night. And if facial nerve function doesn't recover, they should be getting referred to ophthalmology for potentially fitting of weights into the eyelids to help them facilitate eye closure. So Bell's palsy is the one most people have heard of. Now, this is idiopathic facial nerve palsy, and as I say, it is a diagnosis of exclusion. So you've got to make sure that they don't have Ramsay-Hunt syndrome or parotid mass or a severe ear infection that's causing this. So you do have to examine the patient to get to that conclusion. It's not uncommon, 32 per 100,000. It's more common in younger adults. However, it does have quite a good prognosis. Most people, 71 cases, will spontaneously resolve within 2 months. Treatment is oral corticosteroids, typically a tapered course. So we, at my centre, would often give 5 days of high dose, so with a maximum of 1 milligram per kilogram, but 5 days of 60 milligrams, and then taper over the subsequent 5 days, so 50, 40, 30, 20, 10, stop. The kind of protocol for that does vary a bit depending on centres, but broadly speaking, a short course of oral corticosteroids. If you're giving someone high doses of corticosteroids, it's worth prescribing PPI cover during the duration if they're not already on it. As I mentioned, eye care is really, really important if they are unable to, if their eye closure is impaired. So tape to tape the eye shut at night, lac lube ointment at night, and Viscotears or any other form of artificial teardrop during the day. Really important. They should get followed up by ENT in sort of 2 to 3 months with audiology to assess for improvement. And at that point, if no improvement, should be referring to ophthalmology. And then Ramsay-Hunt syndrome is the other one that people are likely to have heard of. So this is reactivation of herpes zoster within the geniculate ganglion of the facial nerve. It's a bit rare, it's a 2 to 5 per 100,000, and it does have a worse recovery than Bell's palsy. The management is very similar. So a short course of corticosteroids. As I say, we tend to use this 10-day course I just described with PPI cover, and eye care being very important as well. However, you'd additionally prescribe antivirals, so something like a 5-day course of acyclovir, valacyclovir being another option. And with both Bell's palsy, Ramsay-Hunt syndrome, you want to be starting treatment within 72 hours of symptom onset. Okay, so then moving on to sudden sensorineural hearing loss. This is defined as hearing loss greater than 30 decibels and at least 3 contiguous frequencies developing over less than 3 days. It's got an incidence of 20 per 100,000 and typically sort of later middle life, so between 50 to 59 years of age. And it's got an unknown etiology. It's often thought to be post-viral infection. However, there's also debate that it could be sort of microvascular impairment to the ear. So assessment, you want to make sure you're not missing another cause of this hearing loss, essentially. So any history of trauma, ototoxic medications, anything that's triggered it, any associated symptoms. You want to do an otoscopic examination, really trying to exclude any kind of ear infection on top that may be actually responsible for the symptoms, and appear to an audiogram to confirm the diagnosis, as we talked about, greater than 30 decibels over 3 contiguous frequencies. For those of you who are not familiar with a pure-tone audiogram, you have frequency along the x-axis and volume on the y-axis. You've got right ears tend to be circles and left crosses, and this is just to give you an idea of volume. So if somebody can only hear things at 120 decibels, that's equivalent to like a jet taking off. So they really can't hear very much. And then again, with frequencies, that obviously higher frequency sounds like birds tweeting or children talking are often hard to hear if you've got high frequency hearing loss. Okay, and this is just an example of somebody with left-sided sensorineural hearing loss. So you can see that they have significant hearing loss in this left ear over several frequencies compared to their right ear. So common practice, we might be getting a theme here of ENT, but corticosteroids for a short course. So again, similar to facial nerve palsy, 5 days at high dose. So not exceeding 1 milligram per kilogram, but something like 60 milligrams over 5 days and then tapering over another 5. So 50, 40, 30, 20, 10, stop. Again, like the facial nerve palsy, prescribing high doses of steroids, it's worth giving PPI cover if they don't already take a PPI. If this doesn't work, there is some kind of variation in practice. Some centres will then try salvage intratympanic corticosteroid injections. However, not everywhere does. and the kind of trial evidence is a bit debated in the efficacy of these different interventions. And again, would recommend ENT follow-up, so 2 to 3 months after with repeat audiogram. And then if you've got persistent unilateral hearing loss at this point, you might consider doing an MRI to exclude an acoustic schwannoma or kind of other intracranial cause of the hearing loss, as well as making sure people are referred for hearing aids and things to deal with this hearing loss. Okay, so now the triaging, the discharging ears, this is a very common referral. So having a bit of a kind of protocol of how you gather the information you need and come to a decision is something I personally found very helpful. So obviously starting which side is it, and is it painful? So if it's painful, it's probably infectious. If it's not, then it's probably a chronic condition. So something like a cholesteatoma. And with the pain, does it keep you up at night? If the pain's waking them up at night or stopping them sleeping, then that's obviously a red flag for a more serious pathology going on. How old are they? So this just helps you triage based on kind of epidemiology. So if it's painful and they're an adult, it's likely acute otitis externa. If it's painful in the child, it's likely acute otitis media with perforation to give them a discharge. And if it's painless, it's likely chronic otitis media with a perforation. What's the discharge like? So this is slightly less robust but helpful. So it's green, custard-like smelly, makes you think acute otitis externa or media. If it's watery and clear, makes you think chronic otitis media with perforation. And if it's thick and white, that's classic of a fungal infection. And then making sure there's no red flags, which mean that you've got to see them urgently. So is the canal patent? Can you see the eardrum? Because complete stenosis means you're going to want to see this patient quicker. Have they got any associated pinna or periauricular cellulitis? Again, which would need an ENT review, may involve hospital admission if it's nasty. And have they got any associated cranial nerve palsy, which is obviously a red flag for serious infection, possible necrotizing otitis externa. And then gathering some information about what treatment have they had so far. So essentially making sure they've had some topical antibiotics and steroid drops. A lot of times you get referred a patient who's just had oral antibiotics, which unsurprisingly haven't helped. So you want to make sure they've had a period of treatment with the right treatment. There's various brands available and not a lot of evidence to say which you should start with. You could see what your local centre does, but Optimize, Sofradex, Betnazole N, Gentasone HC are all good options. And then this is just a little flow chart. You can get these on ENTSHO, either the website or the app, and just help you run through what we've just talked about. So painful, not, and then following through adult, child, and checking for complications and whether they need admitting or not. Okay, so now we've got some interactive cases just to put everything we've just talked about into practice. Now, we do have the poll results from when this session was originally run to kind of go through. And if you are watching this on YouTube, then I'll give you 5 seconds sort of during the polling to make up your mind before revealing the answers. So a 68-year-old lady presents to a GP with a 2-day history of earache with custard-like discharge from her left ear. She has some associated hearing loss and tinnitus on the same side. And this is her ear that you're looking at over here. So what is your top diagnosis? Should she be referred to ENT now? And what treatment would you like to advise? Now, these are your options. And as I say, I'm going to just start a 5-second timer now. You can obviously pause it if you want a bit more time. Okay. So I can see most people have voted for acute otitis externa, which is absolutely correct. So you can see this kind of inflamed, tender-looking canal with some discharge, sloughing out, which added in with sort of the age of the patient makes it the most likely diagnosis. So should she be referred to ENT now? So this has obviously got a bit of a mixed response from people. So this lady didn't have any red flags for kind of complications of otitis externa or necrotizing otitis externa. So she doesn't certainly need to be treated the same day. And she's not had any treatment with topical antibiotic steroid drops yet. Only 2-day history of symptoms. So it would be reasonable to sort of ask the GP to initiate this treatment. And if that doesn't work, then see her in clinic. So the no group, however, or to see them and do some suction. But as I say, it's very reasonable to ask for treatment to be initiated before seeing them in a clinic setting. And then we've kind of already talked about this, but what treatment would you advise? Absolutely, most of you are right with topical antibiotic steroid drops being the mainstay of treatment. IV antibiotics without kind of any evidence of complication, necrotizing otitis externa not needed. Oral antibiotics, as we kind of talked about, much less effective than topical antibiotics. And this doesn't look like a fungal infection. There's no kind of spores you can see in the canal. So yeah, everyone's right. So we're moving on to case 2. Now everyone's feeling a bit more warmed up. So this is a 5-year-old boy who presents to A&E with a discharging left ear. He has a 3-day history of fever and increasing pain, which improved today when his ear started discharging. His cranial nerves are grossly intact and there's no post-auricular swelling. So what is your top diagnosis? What treatment would you advise? And should he be admitted to hospital? Here are your options for the polling. And I'll give you 5 seconds to have a little think. Perfect, and we'll go through the answers. So I can see that most people voted for acute otitis media, which is absolutely correct. So this is kind of a very classical story. So it's a young child, worsening pain, improves after discharging. And you can obviously see a perforation with some discharge coming out on otoscopy. In terms of moving on to treatment options, so yeah, so kind of see a lot of people voting to treat. So this was a young child who's systemically well, with, I can't quite remember how many days of 3-day history of fever and pain. So I think it comes back to that point of saying most of these problems are viral, so it's reasonable to have kind of a deferred antibiotic prescribing strategy in kind of a young child who's systemically well in themselves, as most children will spontaneously recover within 3 to 7 days. However, he does have a discharging ear, so antibiotic treatment is reasonable, and topical or oral antibiotics are both valid options. A lot of people classically prescribe oral amoxicillin for a short course of up to 5 days. And should he be admitted to hospital? So we've kind of covered this really, but no, he's a young child, systemically well, with the short and no kind of red flags for any intracranial or extracranial complications of otitis media. So then moving on to case 3. So this is a 43-year-old man who presents with a 2-week history of worsening right ear pain, which is now waking him up at night. He's got a past medical history of type 2 diabetes, hypertension, and ischemic heart disease. So what's your top diagnosis and what treatment would you like to start? And these are your polling options. And again, I'll give you the 5 seconds to pause it if you want more time. Okay, so we can see quite a few people are worried about necrotizing otitis externa, which is absolutely right. This is sort of an older patient with multiple comorbidities, including type 2 diabetes, and they've actually got quite a prolonged history of ear pain, so 2 weeks, and it's severe, waking them up at night. So these are all kind of things that should get you worrying about necrotizing otitis externa. And what treatment would you like to start? So yeah, so necrotizing otitis externa is osteomyelitis of the skull base. It obviously needs to be confirmed. kind of following this clinical, so with sort of a CT skull base, and then often in our centre we like to do an MRI skull base as well to kind of characterise any bony erosion, as well as cultures and a biopsy of the canal. And in terms of treatment, if you've got necrotizing otitis externa, you need prolonged treatment of IV antibiotics. So we're talking sort of a 6-week course, and different centres have different protocols, but we typically get this delivered through outpatient nursing, if we can, or district nurses, to kind of avoid really prolonged hospital admissions. And good. So he's now had a scan, and we've talked about scans a little bit, but what type of scan is this? What size is the pathology? What's the green arrow pointing at? And what other abnormalities can you spot? And I'll pop up your polling options and start the timer. So, okay, so can see absolutely most of you right. This is a CT head. So what you want to imagine is that the patient's feet are pointing towards you and they're lying on their back, which will then help you work out which side the pathology is on. MRI skull base is useful for assessing necrotizing otitis externa, but obviously it's not this image. PET CT doesn't really have a role. This is a cancer scan, and obviously this isn't a plain film X-ray. So as you can see, most of you have correctly identified. It's on the right. And now we'll see if you've worked out quite where the pathology is. So you've got, and then what this green arrow is pointing at. So this has obviously caused a fair bit of confusion. It's a bit of a trick question, but this is actually a previous mastoidectomy cavity that you're looking at this green arrow. So you can see the mastoid on the other side, which is sort of aerated bone, and that's been drilled out here. So a little bit of a red herring. And then what other abnormality can you see? So this is a little bit more subtle, and I think my animation note's not there. So we're looking here, so you can see that there's been erosion of the middle ear, so you've actually got continuity with the middle cranial fossa. So that's the other abnormality to spot. Okay, and you can also obviously see, unlike air in the middle ear on this side, we have kind of full of plastic fluid on this side. Okay, so now next case. So this is a 78-year-old man who's referred with persistent ear pain for the last 2.5 weeks, despite treatment with 7 days of Otitis and 7 days of gentasone HC. He's got a past medical history of type 2 diabetes mellitus, hypertension, and hyperlipidemia. This is obviously his ear that you're looking into. So again, what's your top diagnosis? Which one investigation would you like? And what treatment would you recommend? And I'll start the timer. Do pause it if you want more time. All right. So we've got a bit of a spread here. So this is, most of you right, acute otitis externa. Where you can see in terms of acute otitis media, the eardrum actually looks normal. It's pearly white, it's not swollen, it's not red. Again, so suggesting these two are not right. In terms of necrotizing otitis externa, it's reasonable to be worried. This is kind of an older man with risk factors, type 2 diabetes, who's still got pain after a week. However, the clue here is really what the ear looks like, which I think we're going to come on to in the next question, in terms of what investigation you would recommend. So the CT head, CT skull base would be the option for ruling out NOE. But as I've talked about, what's really kind of classic here is that you've got this kind of spores. So this is a kind of classic appearance of a fungal infection, having these spores, and these kind of black-headed spores themselves are of Aspergillus nigra, sort of very classical appearance. So in this case, really microbiology swab is what you want to identify the fungus and check sensitivity. From the history, patient doesn't appear systemically unwell, and there's kind of a clear examination finding for their symptoms. So treatment you'd advise comes down to whether you spotted that this was a fungal infection or not. So yeah, topical antifungals, as most of you have said. And I guess that's always a risk factor of having prolonged antibiotic treatments, that you then prone to getting a fungal infection. Okay, so moving on to case 5. This is a 48-year-old lawyer who presents with sudden onset left-sided facial nerve palsy. Symptoms started this morning and he's not able to crease his forehead on the affected side. He's otherwise fit and well. And this is a picture of him. So which side's affected? Is it likely upper or lower motor neuron lesion? And what grade is his facial nerve weakness on the House-Brackman scale? So again, I'll show you your options and I'll start the timer. Okay, so absolutely most of you are right. Problems on the left side. So you can see on his right side, he's closed his eyes nicely and he's managed to smile, whereas on his left side, there's been no movement of his mouth, not managing to show his teeth, and he's not managed to close his eyes fully. So then, is this likely upper or lower motor neuron lesion? So the clue in this was really the forehead involvement. So lower motor neuron, his forehead's also paralysed. If you had forehead sparing, you'd worry about upper motor neuron, and that would send you down a different route, obviously in terms of diagnosis, and you wouldn't want to be seeing him in ENT. What grade is this? So the key to this is really the eye closure is not intact. So the kind of grades to have in your mind, grade 1 being normal, grade 3 being eye closure is still intact with the weakness, and grade 4 eye closure is not intact. So this guy certainly has a grade 4 or 5. It's obviously slightly subjective scoring, but his eye closure is not intact. And now this is his mouth. So what is your top diagnosis and what treatment would you like to start? And I'll start the timer, and here are your choices. Okay. So absolutely, most of you are right with Ramsay-Hunt syndrome. So you can see these little vesicles. So this is just something to be aware of when you're examining. You want to obviously have a look in the affected ear, looking for vesicles. The other place you can get vesicles with Ramsay-Hunt is in the palate on the same side, as well as also you want to feel the parotid, feel the neck for any lumps, thinking of other causes. Because as we've talked about, Bell's palsy is a diagnosis of exclusion, and it does obviously change the management. So what treatment would you like to start? We can see again, most of you right here, so want to start steroids. So typically, so high dose, so typically in our centres, it's a 10-day course, 5 days of up to maximum 1 milligram per kilogram, but 5 days at 60 milligrams, and then 50, 40, 30, 20, 10 stop. Advisable to have PPI cover and also antivirals. So this could be for acyclovir or valacyclovir for a 5-day course. And obviously we've mentioned this patient can't close their eye. So eye care is really, really important. So making sure they've got tape to close their eye at night, they've got artificial teardrops to use regularly through the day, and black lube ointment for overnight as well. Really, really important. Okay, so then moving on to case 6. So this is a 55-year-old man who presents to his GP with persistent smelly otorrhea despite 2 weeks of topical gentasone HC. This is his 5th course of topical antibiotics this year, and he denies any ear pain, but does report some muffling of sound on the affected side. So which ear is this? What is your top diagnosis and what treatment would you recommend? I'll pop up the options and start the timer. Okay, so a little bit of a spread. So things you're looking for obviously in this picture, obviously is in real life because you know which ear you're looking in, but you've got the cone of light anteriorly, which comes from the umbo, and you kind of got this kind of line to follow forward. So that's sort of how you orientate yourself. And what is your top diagnosis? Most of you are right here. Yeah, it's this cholesteatoma. So kind of sitting in the classic position up in the attic. So making sure that you've had a look all the way around and up in the attic is really important when examining the ear. And what treatment would you recommend? Yeah, surgery is the definitive treatment. So antibiotics, topical antibiotics kind of a role if you've kind of got super added infection, but cholesteatoma is not an infection, and the smelly discharge is sort of classic of cholesteatoma, and it's not malignant, so it's not something you treat with radiotherapy, but it is locally invasive, so surgery is the recommended treatment. And there's different surgical approaches depending on the extent of the cholesteatoma and obviously the patient's anatomy. Okay, so case 7. So this is a 23-year-old lady who presents to the emergency department with a painful swollen right ear 2 days after getting a new ear piercing. So what is your top diagnosis? What is the likely cause? And what treatment would you recommend? And here are the options, and I'll start the timer. Okay. So I can see that most of you are right. The big way up here is really pinna cellulitis versus perichondritis, but you can see this classical earlobe sparing, which is typical of pinna perichondritis. So well done to you guys. Relapsing perichondritis, so this is the one we mentioned. So this is an autoimmune condition, often kind of slightly milder, but would be bilateral pinna perichondritis, as well as involving the nose. So yeah, what's the likely cause? So actually Pseudomonas is the typical one. So pinna cellulitis tends to be skin organisms, so that would be the Staph aureus. But in perichondritis, it's typically Pseudomonas. And what treatment would you recommend? So this depends a little bit on your centre, but often these patients are admitted for IV antibiotics if they've got a severe infection. However, some centres do use kind of oral antibiotics with good bioavailability, so things like ciprofloxacin. So just being aware of what your local centre does. Topical fusidic acid is not enough. It's good for kind of localized skin infections, but not sufficient for perichondritis. And obviously this is an infection, so antihistamines aren't going to do the job. Okay, so now on to case 8. So we've got a 3-year-old boy who's brought to their GP with a sore right ear and scanty discharge. He's irritable, but otherwise well in himself. What is your top diagnosis? So not much information, but I'll start the timer. See what you guys think. Okay. So we've got a bit of a spread, which is reasonable because I didn't give you loads of information. A lot of people going for acute otitis media, young child with a painful ear, very reasonable. And some more of you, the second vote is for a foreign body. So that's really good of you to think, and you're actually right. This is what you see when you look in his ear. So I guess this is just a reason to remind you it's always worth looking in the ear, and kind of persistent discharge from ear or a nose in a child should always make you suspicious of a foreign body. If you have kind of super added infection on top of the foreign body, then would recommend starting topical antibiotic drops because it will help ease the pain and make it easier to actually remove that foreign body. And if it's something biological, then we like to see them very quickly in the classic clinic, emergency clinic. If it's something kind of plastic, tend not to cause lots of problems for you. They'll get seen within the next week or 2 for it to be removed. All right. So thank you very much for listening, and please do check out the rest of the course, which is all available on our YouTube channel. Thank you very much.